we have LAD calcified lesion and RCA CTO for our session, and I'm Margaret Tekin and my coworker Ahmet Shakir. Let me show you what we have. So this is left injection, a little bit outside the catheter, but CX looks okay. Next please. And all we have very much calcification. So this after diagonal, I think this part is suspicion part. We have plaque for sure, but we have to understand how much stenosis we have there. Next please.
Next.
In here we have a calcification. Just at the carina, we have seen it. It's a calcified lesion. It's calcification, as you see. And since we have ischemia, 10% we plan to open this RCA. Although it doesn't look like that much big artery, CX is very good. RCA is only one branch actually, to be honest with you. Okay, we went to distal, which is normal part of the LAD, and we pull back automatically 1 millimeter per second. And now we will come to disease part, which you will see all the way around here. Now we started. So this is the disease part. We can measure the lumen here, but let's see the just at the carina what we have. Again, calcification nodule here. Now, okay, diagonal and proximal LAD is also, this part is calcified, but lumen looks okay. We have a circular calcium, almost circular calcification all the way. Here is better eccentric calcification, but not much superficial. Let me show you.
Distal bar.
Let me show you again.
Yes,
stop.
exactly. Stop.
Stop. Yeah. So can you measure the area? So will be
2 millimeters squared. I don't know you guys, but I find this
yes,
Boston.
no. Yes, exactly.
Yeah.
No.
Yeah.
Yes, and
Okay.
more. Yes,
Yeah.
yes, it is.
Okay. So this part is
2.20.
2.27,
Yes.
2.3.
Very good, very good.
So I want to show you the just carina, because that part angiographic looks like the worst part. Okay. So frame by frame, because now we are distal. Okay, go up. Yeah.
Tightly.
Okay, here, stop. So this is the carina. Just below the carina, we have a nodule, as we see angiogram. You can come back frame by frame. To be honest with you, I like to do in this patient, because it's long disease, if it is possible, I like to do, of course, calcification, modification, and also after that, DCB if it is possible. I like to do DCB here a lot, if I could do. So that's why I will do shock fest, and then C balloon, maybe cutting, even cutting. Then I like to have the perfect result without dissection, and then DCB, if it is possible. What do you think? The distal part is diseased. Look, the lumen area is like 2O. Imagine that this is a stent and under expanded, something like that here. Circular calcification, and lumen is 2.3.
Can I make a point here? At multiple points through here, I could see a lumen of less than 2 millimeters in what's a 3 millimeter vessel. That's critical. So the angiogram, I think, is lying to me. Misinterpreting the angiogram.
But there has been perfusion imaging, hasn't there?
So I think I would need, if I don't believe the IVUS, and I'm wondering if this needs treating.
Yeah.
This is exactly a case that why we should use intravascular imaging. We know from a lot of it's with 0.8.
Epicardial is not ischemic, and less than 2.8 probably is. That's in a proximal vessel. This is quite a long way down a pretty tatty small LAD. Are the numbers the same there? I've got no idea. But ultimately, when you get to a point about a pressure wire, I think that's the right place to go here. The only caveat, and you're going to tell the audience in a moment, John, how do we interpret a pressure wire with an occluded right coronary?
Yeah. So things that I'm seeing on this IVUS run as it's going by at the moment is firstly that the distal vessel is about at least 275, maybe 3.0 in diameter. That we've created a lot of fractures in the calcium. There's our diagonal just come in there. and we've got pretty good luminal gain, maybe a bit of change here approximately, but overall, we've modified that calcium and are now ready to think about what next. And I think your point was very well made earlier on about in somebody who's got a lot of plaque burden, thinking 10 years down the line or 7 years down the line, if they were.
Can you hear us?
Yeah, I hear you very well. So what I did, as you see, we did a shock fest here. I think we have a great result because we have lots of fracture, as I did.
Get the IVUS down, and then
I think we have a good result. This is 3.5 NC balloon. After shock, we didn't do NC. And then we have this one. And next, please, after DCB, this is DCB. Next, please. We keep it 1 minute. Next, please. And
Omar, I
this is
think
final result. So I'm quite happy about the result. No need to do stent, I think.
yeah, that looks fabulous in the LED. Omar, I
Yeah.
think shown there on your